Thank you for the opportunity to present our work. 4 authors have support from NIH funding. We know that urinary incontinence is extremely common. Breast cancer survivors in particular are at increased risk of urinary incontinence due to age, a risk factor for both breast cancer and incontinence, as well as iatrogenic effects of anti-estrogen therapy. We also know that a common barrier for urinary incontinence treatment is patients not seeking care out of fear, embarrassment, or the perception that nothing can be done. In the United States, Medicare is a national insurance program for individuals 65 years of age and older, and all Medicare recipients are encouraged to attend an annual wellness visit. The goal of this visit is to identify modifiable health risks and prevent functional decline with suggested behavioral changes. Urinary incontinence screening is encouraged and, although not mandated, this has been a Medicare quality metric. Given that this visit is a screening opportunity for chronic conditions like incontinence, we hypothesize that breast cancer survivors who attended an annual wellness visit within 2 years of their cancer diagnosis were more likely to have documentation and/or treatment of urinary incontinence than those not attending this visit. This was a retrospective cohort study using the SEER Medicare-linked cancer registry from 2011 to 2014. We included women diagnosed with stage 0 to 3 breast cancer who were enrolled in Medicare Parts A, B, and D at least 1 year before their cancer diagnosis and were alive and still enrolled in Medicare at least 2 years after their diagnosis. The 2 cohorts were defined as those with an annual wellness visit and those without, identified by CPT billing codes corresponding with annual wellness visits listed here. The primary outcome was the percentage of women in each cohort categorized as a urinary incontinence patient within 2 years of their breast cancer diagnosis. This was a composite outcome defined as a patient who had 1 or more of the following. First, 1 or more urinary incontinence diagnoses in the billing codes reported to Medicare. Second, 1 or more filled prescriptions for the medications listed here to treat incontinence. And third, report by billing code of procedural treatment including periurethral bulking, implantation of a neurostimulator, urethropexy, sling placement, or chemodenervation of the bladder. Descriptive statistics are reported as percents with counts as well as means with standard deviation. Chi-square and students' t-test were used to compare categorical and continuous variables respectively. Multivariate logistic regression was performed to examine the association, that is, reporting odds ratios with 95% confidence intervals, of the composite outcome with receipt of an annual wellness visit after adjustment for other covariates. We plan to include the covariates listed here in this analysis, including urinary incontinence diagnoses and treatments reported prior to cancer diagnosis. 12,709 breast cancer survivors met our inclusion criteria. 19% had attended an annual wellness visit and 81% had not. There were statistically significant differences between the groups. Women who attended an annual wellness visit were slightly younger, more likely to be white, married, have greater income, have less comorbidities, and have earlier breast cancer stages at diagnosis. Overall, 12% of all patients, 1,510 women, met the criteria for urinary incontinence patient status. This was not different between groups. 9% of all women had an incontinence diagnosis reported, which was not different between groups. Neither pharmaceutical treatment nor procedural treatment was different between groups. Pharmaceutical treatment was reported for 6% of all breast cancer survivors, and procedural treatment was reported for 0.4%. Multivariate analysis with planned covariates was consistent with these findings. Women attending an annual wellness visit were not more likely to be an incontinence patient with an adjusted odds ratio of 1.0. The most powerful predictor of being an incontinence patient in the logistic regression model was pre-cancer incontinence status with an adjusted odds ratio of 17.5. Given the large impact of pre-cancer incontinence status on post-cancer status, we performed an ad hoc sub-analysis on the group of women with no prior incontinence diagnosis, procedure, or medication reported before their breast cancer. Of these 11,314 women, 19% had attended an annual wellness visit, 81% had not. 6% of these women met the composite incontinence outcome, which was not different between groups. Neither incontinence diagnosis nor treatments were different between groups, seen here, which was confirmed with multivariate analysis. The strengths of this study include the large number of patients in this cancer registry, as well as the increased risk of incontinence in our studied population. The limitations include the reliance on administrative data. Additionally, breast cancer patients have other more pressing health concerns than incontinence and may not have prioritized this issue within 2 years of their diagnosis. Finally, we were not able to adjust for patients attending non-annual wellness primary care visits as a covariate. In summary, despite Medicare's goals for annual wellness visits to identify modifiable health risks and improve overall health, these visits were not associated with improved urinary incontinence care delivery for a high-risk group, breast cancer survivors. Previous diagnosis or treatment of incontinence was the most powerful predictor of post-cancer diagnosis or treatment for this condition. Future studies should examine what interventions, including a better focus of annual visits recognition of conditions like incontinence, could help maintain the functional status and quality of life of all patients, including breast cancer survivors. Thank you.